Good morning, everybody, and welcome to East Lansing as the host program for this year's retreat. We're going to start the day actually at a macro level, or somewhat macro level, talking about ACOs and how that's going to affect our practices into the future, and actually how that's going to affect the training of our residents into the future. I just know locally, we're just really excited, even starting to move it to the micro level, but actually having a care coordinator again for the first, well, not for the first time, but again, and actually having pharmacists in our clinic, and just the help that's already caused. And just a very short story about, we had our care coordinator the day she started through the MyPick program here in Michigan. She really hadn't started yet, but we had one of those clinic urgencies. A patient whose spouse wasn't doing well, I don't know the exact story, but actually would not leave the exam room. I think many of us physicians have had that. She wanted to be admitted to the hospital because she didn't feel well. Several faculty members, several residents, and nurses all were working on a way to get her home. None of it was working. Care coordinator said, let me see what I can do. Went in, talked to her for a while, and in the end, she was admitted to a care facility, paying out of her own pocket, but she was more than willing to do that because she just needed a respite from home. Only the care coordinator could have done that. I checked with the faculty, I'm like, could you have pulled that off with more time? No. Only the care coordinator could do it, and it was just a miracle at that time. So we're going to start out with ACOs this morning with Dr. Ramsay. And then we're going to have a panel discussion with many distinguished people, Dr. Allan and Dr. Smith, my predecessor in the program, put together this program. And then in the afternoon, we're going to talk a bit about patient-centered medical homes at the micro level. So at this point, I'd like, oh, and one thing just in case, when you look at your program, the final two topics of the day are going to be switched. So Kelly Clark will be talking from 2:30 to 3:30. I hope Kelly knows that. And Rebecca Malwin will be talking from 1:30 to 2:30 time. So just a switch of times. So at this point, I'd like to introduce Dr. Wadland, who will actually get the program started.
So thank you, David. David's the new program director at Sparrow, so I'd like to congratulate him on his new position, and let's congratulate him. As we all know, our Department of Family Medicine is statewide. We view the campus as the state of Michigan, and that's why you are all here from across the state. So I want to particularly recognize those that came so far, particularly from the Upper Peninsula. Stuart came all the way down. So we have really representation statewide. Also the panel, if you look at the panel, is statewide. Members of the panel are connected to the department, except for one member, which is University of Michigan. They've been very progressive. They finally discovered family medicine and have really moved ahead. Phil Zarzov is here from University of Michigan, who's the chair. Is it now official or interim chair? He wants to be chair on his way. Phil, I'm glad Phil came here from University of Michigan. So the big question is, who is Allan Ramsay? Okay. Before I answer that question, I'd like to sort of tell a story. For years here, I've been teaching the health policy course. The College of Human Medicine has a great course, and those of you who enjoy teaching, I recommend that you get in and teach that course. You really learn a lot. And part of that course, we had studied the blueprint for Vermont. And that blueprint came out about, I think, 2007, 2008. Was published in the New England Journal. So I knew about it. And then last year, I got a special invitation to go back to Vermont. Some of you know that before I came here, I was a faculty member in family medicine, same department that Allan's in. That's how I knew Allan. And it was a special invitation to go back and do a high-level consultation on advancing research in family medicine. for that department. So it was a real honor that they would actually ask me to come back. In that visit, I got to meet the head of the group practice, researchers across multiple departments. I met with the provost of the university, and it was quite clear that not only was there a blueprint for Vermont, but a whole blueprint in how the university and the group practice was linked into healthcare across the entire state. And they were reorganizing healthcare. At the same time, this article, which you have a copy of, on the evolution of this payer head in the New England Journal, had come out. And I read about this Green Mountain Board. And I thought, boy, this is really the next iteration. It's coming right out of the governor's office, basically. So I came back to Michigan, and within a month or so, there was an announcement that they had selected. I think there were, Allan had mentioned, about 500 people wanting to get on this board because it's such power. They had selected Allan Ramsay. And I thought, wow, that is really smart. Somebody's really smart in the state of Vermont. So why is that smart? Who is Allan Ramsay? Well, Allan grew up in Ann Arbor. I don't know if that made him smart. He told me today he's always applied to the University of Michigan but never went there.
That wasn't smart.
Yeah. So I went to the University of Florida undergraduate, went to Emory, did his medical training there, was on a fast track, did in general internal medicine, but had a real passion for family medicine. That's back when family medicine was just getting its identity. Got into, I think, the National Health Service Corps, and then did the National Health Service Corps in Colorado. Brushed up on being really a comprehensive generalist, got some special training. So was a full blast family physician in rural Colorado. That means he did peds, obstetrics, inpatient care. And then joined the faculty at the University of Vermont. So very rural focused experience. When I came there as a faculty in the mid-'80s, Allan was already there for several years, the residents said, he is our teacher. And he had got the Outstanding Teacher Award a number of times. So I decided I better try to emulate him, and I better watch him, okay? So I did that, and actually got close with him, became good friends. During my stay there, Allan not only was recognized as outstanding clinician, teacher, he became chief of staff of the Medical Center Hospital of Vermont, so is acknowledged for his leadership. Since that time, before he got on this board, he then led initiatives for the seriously ill, and the initiative that involves the seriously ill, of course, is palliative care. He set up palliative care systems, not only for the hospital, but now has gone statewide to the statewide system across Vermont. And I think that's partly why he was chosen for this board. He then is selected for this board, gave up his full professorship in the university, took a pay cut to do that. He cannot accept an honorarium because he's a state employee, so a number of you know what that's like. So he's here, glad to be in Michigan, sort of back presenting with him. So I think they were really wise to choose an excellent family physician to be on this board. And who was wise? It was really the governor of the state, basically. So let's recognize Allan Ramsay.
Wow. Well, thank you, Bill, for that kind of biography and a really nice introduction. And thank you all for being here. This just was wonderful to accept this invitation. I got it back in March. I was just kind of cutting my teeth around healthcare policy. And this is the first time that I have several coming up, but this is the first time I've spoken really out of state. And particularly around being invited to talk about family medicine, primary care, and healthcare reform. My brother's a family doctor, my sister-in-law is a family doctor, I'm a family doctor, it runs in my veins. So you are going to hear how primary care and healthcare reform are so tightly linked. Today we're going to talk about, this is a residency retreat, we're going to talk about some things that we and our residents need to know. Having done lots of academic talks, we always start out with the disclosure statement. I have nothing to disclose. Bill's already done that. I can't take an honorarium, I can't take any contracting fees or consulting fees for any work that I've done for the state. My salary is a tad over $80,000. When I talked to my wife about taking this job, she said, wow, you know, does that mean you retire from Fletcher Allen and from the college? I said, yeah. Well, are they going to pay you? Disclosure. I say, yes. Well, how much? I give the amount. Long, long, long pause. A little longer pause. I say, well, you know, there's good news. Another long pause. Number one, our tax bracket is going to plummet. And it did. Number two, when they all of this is transparency and openness. That's what state employees have. Number two is when they announce the top 200 state employee salaries publicly, I won't be on the list. But more importantly, and then finally I said, Ann, this is the art of the possible now. This is truly the art of the possible. And I need to be involved, and family medicine needs to be at the table. So that's what we're going to talk about today. So we always have goals and objectives. Number one, we're going to learn a few teaching points from someone who's been involved in healthcare policy, someone who is dedicated to making sure decisions about family medicine and primary care are made in a thoughtful way. Number two, we're going to talk about payment reform models that lead to accountability without compromising our autonomy. You're going to hear me talk about that over and over and over again. The preservation of professional autonomy in the setting of organizational accountability, accountable care organizations. That is so important to every one of us that walk into the room and close that examining room door. And number three, we're going to understand why family medicine, patient-centered medical home model, and federally qualified health centers are a foundation, not only in Vermont, but everywhere. Why did I apply the Green Mountain Care Board? I started out with that introduction about the art of the possible. What I learned after 32 years in the academic model is that there are some very powerful limitations about affecting policy in a meaningful way from the inside. I knew that I had a significant lack of knowledge about the public policy world, but I love learning. And Vermont seemed like the right place. Vermonters care about each other, they trust each other, they can adapt to change, just like the people that I grew up with in Michigan. Exactly like that. And it's really not about us, it's about them. So I know when I leave the state that people will think, oh, Vermont. Let me reassure you about a couple things. At least when I left yesterday, there were no declared socialists in any public office position in Vermont, okay? Sure, we have gay marriage, we have marriage equality, we don't have physician-assisted suicide. Vermont is just like Michigan. Things can be done in Michigan just like they're done in Vermont because it is about the people of Michigan. I truly believe that. Well, I'll have to admit to one thing. One of my most interesting days in the State House last year was when our undocumented migrant farm workers marched on the State House with their translators to demand the Department of Motor Vehicles allow them to have Vermont driver's licenses. It was a wonderful debate in the Senate Transportation Committee, open, and it's still being decided. I don't know if other states do that. I doubt it. I know this is an agricultural state just like Vermont. But what it did for me was to help me decide, okay, how are we going to include undocumented migrant farm workers in Green Mountain Care? And I believe we probably will. So Vermont is a little different in some ways, but in most ways it isn't. Let me reassure you, okay? Most importantly, I hope to nudge primary care policy wherever possible. Now, I have to give you a foundation in what's going on in Vermont, more than what you saw in that article by our chair, Anya Rader-Wallach. Act 48, passed by the legislature, signed by the governor in the 2011 legislative session, was a three-component act. One, which Bill talked about, the Green Mountain Care Board, 5-member board with regulatory and policy responsibilities for reforming the healthcare system. I'll explain that a little more. But really focused on cost containing, improving the health of Vermonters. You'll hear me coming back to Michigan as I make these comments, because no state can afford the healthcare expenditure trend that they're currently on when you compare it to their gross state product or their overall economic growth. None. Vermont can't, Michigan can't, no other state can. So that was our charge. We are a separate independent board. When the governor calls, when he made his announcement, we no longer answer to the governor, the administration, or the legislature. That is a plus. There is a negative. We are not an elected board. We are appointed. We are appointed by elected officials. The search committee included members of the House, Senate, and the administration. But we are independent. The other two components can come out of the administration. One, the Department of Vermont Health Access, which is basically our Medicaid managed care organization, creates the exchange, expands insurance coverage, and expands the blueprint primary care for health. The third component comes out of the governor's office to his director of healthcare reform, which is planning and operational, which is operational and financial planning for a single payer system. Now, the governor has been very adamant in all of his public comments about wanting Vermont to be the first place to have a single payer healthcare system. The Green Mountain Care Board is a fully independent entity. We don't know what the future holds. We do know, and the governor has stated, there will not be public financing for a single payer healthcare system in Vermont unless the costs, the overall expenditure trend in Vermont, the cost of healthcare are below the overall economic growth in the state, which now sits at about a gross state product at about 2.5%, may get to 3% this year, we're not sure. Healthcare expenditures have always been above that. Okay. So though it's a nice talking point, we don't know what the future holds. What are our responsibilities? We review and approve all hospital budgets. We just completed that in our 14 hospitals. 2 hospitals had to go back and resubmit their budgets. We told them in April, you submit to us a budget with no greater than 3.75% net patient revenue increase. We gave them exemptions, we call off-ramps to that. They submitted budgets with an average of 7.5% net patient revenue increase. We adjusted 8 hospitals. We had 6 hospitals and CEOs and CFOs come to testify before the board. 2 hospitals were only tentatively approved because they had to start their fiscal year in October 1, and they will have to resubmit. Also, certificate of need, final approval of all insurance rate increases. This all works together because when you submit a hospital budget, for those of you who do them, you know you also submit a rate increase. Where does that rate increase go? Right to your commercial payers. What are your commercial payers faced with? The cost shift. Because the only way 50% of the funding of healthcare in this state, in our state, the only way that 50%, which is publicly financed through Medicaid and Medicare, can control costs is by cutting reimbursements. That's the cost shift. We approve a benchmark benefit package for the exchange, and we hope a more comprehensive benefit package for Green Mountain Care, and most importantly, adult dental. Payment reform, we're going to talk a lot about that today, workforce plan, an information technology plan, and a whole lot of other things. It is almost intimidating to think about this. Even after a year, we have a wonderful staff, and it's a work in progress. So what are the goals? Insurance coverage and coverage, whatever you want to call it, and access to high-quality, fully integrated healthcare services for all, greater equity and fairness in how we finance healthcare. This cost shift, not sustainable. You talk about a fiscal cliff. Talk about the cost shift to your payers, to your commercial payers, and to your CFOs. Reduce the rate of growth in healthcare costs more closely with our alignment to pay and to prepare. This is where I come in. This is kind of healthcare policy, wonk, data-driven, a lot of it is, but this is where I come in. Prepare and teach my colleagues about the need for reforming the system, which in their mind really starts with payment reform. So what is our timeline? Control the costs, get away from fee-for-service, we're going to talk about that, paying for value, a simpler system. The benefit exchange, we spent a lot of time on developing the benchmark benefit package for our exchange. I know Michigan is not engaged in developing its own statewide exchange. At least that's what I read from your Speaker of your House. I believe that there's concerns about the Medicaid dollars that are going to support the exchange over the first 2 years, drying up after that, and is that going to come out of your state budget? Is that going to be a taxation increase? There's all those concerns, we know that. But when you either do that according to the Affordable Care Act, or the federal government comes in and sets up the exchange for you. Lastly, Green Mountain Care, which is down the line. One payer we think, we're not sure. Maybe public financing. We would need to get a waiver from Medicare so that we could manage the Medicare costs within the state. We hope that will come as part of the Affordable Care Act. Here's the Holy Grail. You have a budget, I have a budget. My wife knows what our budget is now, that's for sure. We need a unified healthcare budget, and every state does. And every state's different here. Michigan is not the same as Vermont. We hope that these tools will lead us down that path. We are very, very data dependent. And I'll just mention to those of you who do data analysis and more analytic or actuarial or have economic discussions, we happen to be a state that has an all claims payer database already in place called VCures. So we have an all claims, which includes all of our commercials and Medicaid database that we can track, and we've had that for over 4 years. So we can do a historical trend analysis on all of our non-Medicare expenditures. Most states don't have that. All states will need it. Okay, that's the Green Mountain Care Board. I've spoken to many groups. Most of them friendly, not all, by any means, okay? And we are in an election year. So the most interesting day of my life on the Green Mountain Care Board was the morning of, I believe it was June 28th, when the Supreme Court was making its final decision around the Affordable Care Act. We were having an administrative meeting. One of our lawyers had a direct line into SCOTUS and kind of was on his cell phone. We were all ignoring it. We were all in total denial. Though all the news seemed to say the Affordable Care Act is going to be deemed unconstitutional or the mandate's going to be taken out. We hadn't talked, none of us had even talked about it in the prior 2 weeks. So the word comes through, we all look at each other, and then we just go about our business. And so Anya, our chair, I'm sure she had prepared all remarks for the press about what she should say if the Affordable Care Act is deemed unconstitutional and what are we going to do with the Green Mountain Care Board and all that. She prepared all those remarks. So we asked her afterwards, well, she was heading over to the governor's office. So, Anya, what are you going to say to the governor? 2 words. Don't gloat. And that's what she told us. So that was an interesting day. Now, let's get on to what I think is important for you. Primary care must be the foundation of a successful, accountable care organization. Not can, not should, it must. I wish I could have found a more recent and a more appropriate terminology than general practitioners. But here we are in terms of relationship between provider workforce and quality by all standard quality measures. The more primary care you have, the higher your quality rank. Vermont is here. I think I found Michigan. Yeah, it's a little further down. But this is 10 years old. Okay, this is 10 years old. Okay, but the point being, and let me give you an example. Sharp, the most senior accountable care organization, one of the most senior accountable care organizations is Sharps in San Diego. Okay. So they start to develop their delivery system after they're approved as a shared savings ACO, as a pioneer ACO, and they realize, my goodness, our attributed lives, our Medicare beneficiaries don't have primary care doctors. What are we going to do? That was the first thing that they realized. And a lot of people who are applying, entities that are applying for accountable care organizations are realizing that same thing, and they're getting ratios like, gee, we survey our members now, we've got 10,000 covered lives or 10,000 Medicare beneficiaries, and only 1 out of 4 have a primary care physician. That won't work. Okay, now, so we need to have enough. The more important thing, we need to have leadership among our primary care communities. We have got to take responsibility for redesigning the delivery system to emphasize prevention, improved outcomes, and even avoidable complications. We cannot do that without payment reform, and that's why I'm going to spend a fair amount of time talking about payment reform. No doctor in this room could debate me about whether they've ever had fair compensation by all the payers that deal with their claims. Medicaid, Medicare, commercials, negotiated contracts, managed contracts. It's never been. There's never been uniform fairness to how we're compensated. That's not a business model that's survivable. We cannot look to insurers, drug companies, malpractice reform, the Green Mountain Care Board, or anyone else to initiate and achieve the changes that will improve our value. I get all kinds of comments like that. Why can't you get rid of direct-to-consumer advertising on all those drugs? Why don't you fix the malpractice problem? We cannot wait for those kind of things. We have got to take the leadership role. Now, I talk about the delivery system. This is a clinical model. This is what an accountable care organization is going to have to do, and they all start, those that look at this pilot, they're all pilots, in a thoughtful way, fairly quickly come to the realization that, and this is why we have to be leaders, the clinicians, it begins with the delivery system redesign. They all want to talk about risk assumption. The Medicare wants us to take all this risk on, but it doesn't start there. It starts with some of the things, David, with your comment about a care manager, making sure a patient got what she needed, improving the patient care experience. Okay. So this is the starting point. Don't even go here. Don't start accepting risk until you have put some things under the hood that really changes the way you deliver healthcare, to focus on quality and value and the patient experience. I'm going to give you some examples of that as we go on. Then you can start thinking about that 2% risk that you might take with no downside for your ACO in the first 3 years of your shared savings program. Maybe you can start thinking about that. But if you start thinking about this first, that 3rd year and 4th year, when you start accepting risk, it'll be just like the old days. HMOs went bankrupt. They took money out of the system and then went bankrupt. Okay? So these are management initiatives, and they have to have communication around the culture. Now, we all look at those places like Mayo, Cleveland Clinic, Geisinger, Intermountain Health, Kaiser, how they have changed their culture to focus on value. What is the commonality among all 4 of those major institutions? It took a lot of time. It took a lot of time. In one case, Mayo, it took over 100 years. Kaiser is the newest one, and they've been around for 30 years. This is cultural change. This is where leadership comes in. And then you have provider change. You have providers starting to think about, okay, this is not a matter of the 10-minute visit to generate the CPT code and the RVU and the number of visits and the revenues and the gross and the net margin and all that stuff. It's not that anymore. Then we'll see a cost trend change. Now, this is when you do an ACO, an accountable care organization, you have a 3-year commitment to doing this work where you're not held at risk. It's not going to be easy because the only model we have is called some of you may have read about this, the Medicare Physician Group Demonstration Project began 5 years ago. It was a 10 large practices, integrated practices, assumed the risk of over 200,000 Medicare patients over 5 years. There was a comparison study group, a control group of similar medical centers. What they found over that 5 years, they saved an average in that Medicare population of $151 per member per month. That's not much. That is not much. It's somewhere between $114 and $150. In terms of overall medical expenditures, that was not a big number. Now, where they saved the most was in the dually eligible population. It had a big impact in the dually eligible, that physician's medical group practice demonstration. But that was an ACO model that looked at delivery systems to improve efficiencies, to improve quality, the patient experience, clear quality parameters, and how it reduced costs. It clearly improved quality, but the cost structure was, the cost savings in that Medicare population was pretty modest. That's one demonstration project where we actually have dollar figures. Okay, so let's talk about payment reform and the ACO. Why now? We're going to talk about the link between payment reform and the patient-centered medical home. I'm going to give you a couple of tell you a couple stories about enhanced primary care and specialty integration. And then I'm going to show you how our residents are part of this process in a very important way, the next generation of physicians. Okay. So, healthcare costs. Thomas Lee, who is the Chief Medical Officer at Partners, which is the largest pioneer ACO in the country with over 200,000 Medicare enrollees. He happens to be in Vermont today and tomorrow. I'm sorry I missed him. But he is a very thoughtful guy. Healthcare costs are the pounding headache to which all of us in medicine will awaken each day for the rest of our lives. Whereas some problems can be solved. That's the primary care, family medicine workforce, can be solved. Others must be perpetually managed and costs are among the latter. All we can do is manage it. There's no one on the Green Mountain Care Board that we took this job thinking that we were going to slash the healthcare budget in Vermont. We were just going to bend the cost curve. And all we had to do was take that 5-year, 7-year cost curve from 6% down to 4%, 2 percentage points to save $1 billion over 4 years out of a $5.5 billion healthcare budget. That's real money. That's what that's our focus. We're not, I tell my orthopedic friends, we're not here to slash the budget. I tell these hospitals, we're not here to micromanage your budget. None of us tell them that. We say we're here to help you change your mission. You don't manage your facility, your entity, your provider group, your hospital to your margin. You manage it to your mission. Whatever that is. If it's a critical access hospital, that's a different mission than Sparrow Hospital. Totally different mission. But you manage to that mission and your margin will follow. And the cost curve will change. So, family medicine residents, they wonder why it's happening. Well, I tell you, when the 12 or 1,400 providers I've talked to in Vermont, it's not residents, it's all my colleagues. They wonder why it's happening. Again, the fee-for-service system, the way we get paid now is based on the volume services we provide rather than the value we can demonstrate. What has been the good of fee-for-service? It's been really good. It's been good. It has made us very productive. We have doctors in this state, in Vermont, in this country who are very productive because the fee-for-service system has made them productive. They get paid for each unit of service they provide. What else has it done? It's made us very good about documenting every single thing we do and developing computer systems that are only there to document every single service, as opposed to tell a story about a patient. Maybe that's good. So it's done a couple good things. I'm not saying get rid of it. How about, and then we talked about the cost shift. I'm not going to spend on that. This is why it's changing. I talked about how half of our financing, which is Medicaid and Medicare, all we're seeing is reductions in reimbursements. And if that SGR is not voted down again this year as part of an amendment, that sustainable growth rate, part of the Medicare law for 10 years, we get a 27% reduction in our Medicare payments. 27%. And that's all, we won't hear anything about that until the very last minute, until we get to that fiscal cliff in Washington. Payment reform has got to be balanced to address quality. Most importantly, the patient experience. It has to do that. Managed care and capitation in the 80s and 90s tried but failed to improve the system. Gave it a shot, tried, failed. Failed social experiment. I became a gatekeeper. Governor understood, when he interviewed me, understood very well when I said, that's not going to happen. I am not going to be on this board. If you take away my autonomy, you make me a gatekeeper and you just focus, and this cost control is all utilization. I was just, hey, I'm out. Actually, it was funny, the only real argument, he agreed, the only real argument we got into was, what was the best job in Vermont? This is kind of fun. Because I said, with all due respect, the best job in Vermont is being a family doctor. Oh, no. The best job in Vermont is being a governor. Okay, well, let's get some examples out here. Because we had had Irene, we had had a hurricane come through Vermont, and that just consumed everybody. And then he thought about what he had to do to get us through Irene, and he says, well, maybe you're right. Maybe being a family doctor would be the best job in Vermont. But let's talk about this managed care thing. Because accountable care organization, managed care organization, HMOs, people can kind of confuse those, but let me tell you what is different. What I rely on to be different. An accountable care organization is a provider group or entity. Of the 120 or so that have been approved by Medicare for shared savings, 85% of them are provider-based. Another 25% of them are a combination of a provider-hospital network entity. It's not an insurer. An accountable care organization is not an insurer, like an HMO used to be. Okay? That's number one. It's a very important distinction. Number two is freedom of choice. When you were in an HMO, you had to stay within that network. You could not go outside that network. The accountable care organization does not deny you the freedom or any patient the freedom to go wherever they want for their care. Okay. Number three, HMOs transitioned all the financial risk to the provider. It made it easy to budget because you were just going to provide that. You were just going to pay that person per member per month. Okay. It did not develop a system where there was shared risk between the provider group and the payer. And lastly, there was nothing in HMOs that really focused on quality. The accountable care organization started out, the federal rules started out with 65 quality indicators. They carved it down to 33, but you are not going to share in those savings unless you can demonstrate improved quality. At least those four things gave me some hope that I would never be a great gatekeeper again. Okay, now let's talk about how you, now the residents, you guys are sitting around saying, what's he talking about? That's kind of wonky talk, you know. Okay, here's the issue. We are psychologically dependent. We are addicted to fee-for-service. It's an addiction. I worked in a Day One, which is a substance abuse treatment center as a medical director for 7 or 8 years. So my career, I took care of a lot of people who were addicted, who had dependency, okay? Now, how are they similar? When you are psychologically dependent, you are in denial. When you see an alcoholic in the office this afternoon, they're going to deny that they are alcohol dependent. We denied that we are dependent on fee-for-service, especially my specialty, particularly those who do procedural medicine. Okay? Think of it that way. There is harm. When we do fee-for-service medicine exclusively, we may do harm to our patients. Really. There is loss of control. We don't do watchful waiting. We take them right to the operating room because the incentives are there to do that. So if you can't understand fee-for-service in any other way and why this needs to change, think of it as a psychological dependence, and you need to be the intervention. You need to help us get over this, okay? Now, payment reform models. Right now, we're in all-payer fee-for-service rates. Hospital budgets with fee-for-service payments and a revenue cap. That's what we've started to do in Vermont. It might take legislative relief, but it can be done in any state. We now are expanding the blueprint to really focus on this integration between primary care and specialists. The blueprint in the patient-centered medical home is expected to coordinate care over the whole continuum of services, but it has not held the specialty side of services accountable for any of that care yet. We have to change that. Physician hospital budget with prospective payments. That's maybe an enhanced payment network for a hospital physician group that can start to take some risk for reduction in healthcare expenditures, and finally the ACO, the shared savings model. Now, our patient-centered medical home is embedded basically in all those models. Okay, now does primary care mean lower costs? Here's the same Medicare database, claims data. The more primary care physicians you have per 10,000 patients, the lower the costs. And this was 10 years ago. Michigan, I think, is right in this cluster, but I know it's better now. This is 12 years old. I know it's better. But this is just a curve about what an accountable care organization really needs to know. More primary care means lower costs. So, how do we change the system? And it all comes down to the delivery system. So now let me tell you specifically about the patient-centered medical home model. And I keep coming back to this process of care. Two important issues. The process, the delivery system, and the patient experience. So in Vermont, the Blueprint model helps us to begin to teach team-based care. We were an advanced primary care practice, multi-payer. So as opposed to Michigan, where your patient-centered medical home network was primarily a single payer with a, I think it was called by Blue Cross Blue Shield, and you might correct me on this, a physician compensation incentive program to enhance payments. Not all your patient-centered medical homes were based on FQHC standards, and you basically were single payer. We were multi-payer. I'll get to that in a minute. But it starts with the advanced primary care practice. Now what you'll see in each of these blocks is coordination. That was a great story. Coordination of care, panel management, okay? As you go up the severity, you become eligible for the community health team, which is, again, a higher level of coordination of service, referrals, case management, Medicaid care coordination, seniors living safely at home teams, that's housers and home visitors, self-management support counseling, nutrition, diabetes, and population management, that's the community health team. And the last iteration is the specialty care, advanced assessments and treatments and integration. Okay? So you move up this block, these blocks, as you have a more chronically or seriously ill population. Now, and this is the expansion. I mean, these are Blueprint sites all around the state. Lots of red dots. Pretty much the whole state is covered. And this is the breakdown for the hospital, for the primary care practices. As of January 2012, 47% of the primary care physicians in a patient-centered medical home were hospital-based, hospital-employed. 28% were independent practices, and 25% were federally qualified health centers. So here's the numbers. So we had, as of January, out of our 650,000 population, we had 353,000 enrolled in patient-centered medical homes. And by mid-2013, that'll be up around 500,000. I believe all of these are important models to sustain. This is the most vulnerable model, because when you go through a patient-centered medical home FQHC evaluation of 110 critical indicators, it takes a ton of administrative work. Luckily, the Blueprint office has been financed through statutory ways in our Medicaid office to provide significant support to the smaller independent practices to achieve that certification. But we believe strongly in that, using that as a consistent foundation. This is vulnerable, very vulnerable. I believe this model, and in Vermont, in Michigan, 65% of your primary care physicians are in these smaller independent practices. They have to be supported to achieve this recognition. Now, when I say multi-payer, what that means, as opposed to the Blue Cross Blue Shield model in Michigan, is that we are paid, our patient-centered medical homes are paid by Medicaid, Medicare, Blue Cross, MBE, Cigna, and the self-insured population. Everyone puts money in the pool to support this model, because we've been able to demonstrate this is the way you're going to reduce costs in your commercial as well as in your publicly financed population. Now, the other thing, and it's a per member per month based on primarily on quality indicators. There's still fee-for-service payment embedded, but it's enhanced in fee-for-service balance. It's still very heavily weighted towards fee-for-service, but the goal is to transition more to an equal balance between a per member per month and a fee-for-service compensation plan. Now, when I say shared cost or utility, people go to the community health teams, it doesn't come out of their deductible, there's no copay. That's a service they all get by being a member of the patient-centered medical home. So a person comes out of the hospital with a heart attack and they don't want to go to rehab and they don't understand their medications or a good nutrition plan for their coronary disease or diabetes. The family doctor sends them to the community health team, they don't pay a thing. And the community health teams are pretty much located within the practices. How has it been a job engine? I don't know. This is, because everything in Vermont, just like here in terms of overall economic growth, is how can we create jobs? Create jobs in the healthcare industry. Healthcare reform is clearly going to be a job engine. Every state, it's going to be a job engine. What we've seen just in the last year is this growth in core community health team jobs. I don't know where statisticians say 74.9, so let's just call it 75, okay? So we've got 75 new jobs created. Most of them have been in the last 2 years as the community health teams have been established and training programs have evolved. That is so important. Now, I talked a little bit about the workforce, but I have some basic thoughts about the workforce, but we have to approve a workforce plan for the state of Vermont. What we want to do is to be sure, this is one of Dr. Wadlin's patients saying, will I still be able to not exercise after his heart attack? And Dr. Wadlin sent him to the community health team. Way to go, Dr. Wadlin. Reform must assure the growth of the workforce is focused on those providing primary care, whether it be the community health team, family physician, the internist, pediatrician. In New Hampshire, where we saw since their comprehensive insurance coverage plan was put in place 4 years ago, we saw an increase in healthcare-related jobs in New Hampshire that outpaced the national trend by about 9%. But unfortunately, most of those jobs were in administrative management roles, not in delivery roles. And we don't want to repeat that. And I don't think we need to if we just look at it in a thoughtful way. Darn, I'm getting late. So federal FQHCs are integral to those of you who work in the FQHC environment, you saw a large percentage of our statewide FQHCs were early engagements, had early engagement in the blueprint in the federal qualified, in the patient-centered medical home. There were some Affordable Care Act requirements about the exchange, people in the insurance coverage in the exchanges had to contract with FQHC. So there's some relief in the Affordable Care Act for FQHCs. Plus, the most important thing is that National Service Corps eligibility for healthcare providers working in FQHCs in Vermont is assured. And that's how I ended up in the National Service Corps, to pay off my loans, at least part of them. That was a long time ago. So FQHCs are pretty integral, and we have this network, which is kind of scattered, but there's over many service areas are covered, and this is Michigan's FQHC network, which is very good and growing, according to the HRSA data warehouse in 2011. And just to show you what this means to the population and to the healthcare and to coverage, getting everybody in the tent. This is the growth in Medicaid and public assistance population in Michigan, in FQHCs, and this is the growth in uninsured. Now, this is uninsured, and this is the growth in the Medicaid population. You can see the FQHCs are serving a very important and vulnerable population in all of our states. I love this. I was visiting Northern County, is one of our larger Hardwick Health Center, and you walk in the door and on the bulletin board it says, "Call us first. Don't go to the emergency room. Call us first." I mean, that's the kind of model that's just love to see. So, we know where the waste is in the system. I talked about this last night. Even in states that have high quality, low cost systems, there is enough, there are places to target. When I say failures of execution, I don't necessarily mean, as I talked about last, a diabetic not getting a flu shot. It's just not getting preventive health. Not having a primary care doctor to give you preventive health and intervention. Failures of integration, this is typically the people that fall through the cracks. Anybody in the room that takes care of people know they fall through the cracks. Who falls through the cracks? The sickest people. The people with mental health illness, the people with seriously ill conditions, they're the ones that fall through the cracks. We have to change that. Over-treatment, I'm not going to get into. That basically is habits. You form habits for doing things that don't change and are driven by volume and prior service and reimbursement systems. Administrative burdens, common reporting forms, we don't have those. All your commercial payers don't have a common reporting form or billing form. Pricing failures cost 3 times as much to get a CT scan anywhere in the United States as it does in Europe. I don't think this is huge, but all my colleagues like to talk about it. Now, this is not, this is a pilot. The patient-centered medical home, payment reform are pilot projects. We have seen, in Michigan, you've seen some fairly dramatic reduction in costs in your patient-centered medical home model by single-payer analysis through a commercial population, Blue Cross Blue Shield. Decreased hospital readmissions, decreased emergency rooms, but that's a commercial population. When you start putting Medicare and Medicaid into that population, it's a more difficult analysis. The administrative costs we talked about. Are we going to have incentives to care coordination that penetrate throughout the system from primary care to specialty care to hospital care? Are those incentives going to, that's a leadership cultural change? Are we going to have leaders that can make that happen? And we talked about the Medicare Physician Group Demonstration Project, the only model that shows some degree of shared savings in a Medicare population. It's still untested, but it's a start. So one of the things the Green Mountain Care Board has to do is to approve payment reform pilot projects. So we went to a community hospital, it's a critical access hospital in the Northeast Kingdom. We've been in Vermont, knows about Vermont, knows about the kingdom. It's in the northeast part of the state, just an unbelievably rural and lovely place. And started talking, okay, what problems do you have with your delivery system? Well, we've got the Norris Cotton Cancer Center here, which is a satellite of the Dartmouth-Hitchcock nationally certified cancer center, Norris Cotton Cancer Center. And the family doctor started saying, you know, even in this environment, if somebody gets cancer and we lose them. We don't see them anymore until the very end. And the oncologists started to, well, I'll say that this kind of fed into my real passion for palliative care, because I think if you get cancer, you always need palliative primary care. You almost always need oncology care, and most of the time you need palliative care. I would say all the time. But there are still a few patients that exist like they did when I started practice. When I started practice and I took a family history, how did your mom die? You know, she was like 80, she up and died. Oh, okay. How about your grandfather? I think he was 75, he up and died too. Nobody up and dies anymore. But if you do happen to up and die, you don't need palliative care. I walked through the airport in Detroit, and I saw so many older, frail people, walkers, wheelchairs. And this is not bad, but there's an AED every 100 feet. And the people that don't get the AED probably have an implantable defibrillator. And we got a transplant. We've got disease-modifying therapies that you could never imagine when I started out. And then people just up and die. So they didn't know it. They didn't need palliative care. Everybody else does. So what we did was we got the community hospital, the cancer center, the patient-centered medical home, and the home health agency at the table. What are your problems? I just stated them. Family physicians lose track. Oncologist said, I didn't want to give them that chemotherapy in the last 2 weeks of life, but I just felt like the patient pressured me into it and I didn't have any alternative. And then the palliative care team says they consult us too late. And then the payers say, oh my God, the rise in costs of drugs and imaging in the last 30 days of life is driving us crazy. So then we hired a contracting firm to help us do the analytics. We paid for part of that, but each of the organizations put some money into it. And we did the cost analysis. We did the cost analysis for cancer patients in that service area. Just to show you, this is a small community critical access hospital. We looked at the entire state. If we were able to reduce the cost of cancer by 5% over 4 years, 7% or 10 years, or 10% over 4 years, you know, we get into millions of dollars and you're talking real money. But we went down to the community hospital, just the commercial and Medicaid. That's only, you can't mess with Medicare money. But the commercial and the Medicaid, if we cut their cost by 5%, 7% or 10%, we said, gee, if we can do that in 4 years, we're going to save you $2 million. So we developed an integrated care management plan with a palliative care team, oncologist, a patient-centered medical home. We developed process metrics. You don't need to know the details, but it's around, you know, established National Comprehensive Cancer Network and ASCO guidelines. The payers agreed to pay $80 per member per month enhanced payment for this model. And the Green Mountain Care Board, who are required to develop these payment models, approves it. And then we start thinking about an expanded model to do this for all people with serious illness throughout the state. Okay, now, many of you have heard, some of you heard about the Choosing Wisely program. These are a group of 9 specialty groups who have said, who the ACP, the American College of Physicians, went to and said, give us 5 things that don't improve value and increase costs. Just 5 things that you guys all do. So they all chipped in. The American Academy of Family Medicine, Family Practice chipped in. So we have Choosing Wisely, which is supported by Consumer Reports, which is giving out entity scorecards now around Choosing Wisely. One of my fellow board members, Karen Hine, is on the board at Consumer Reports. But let me give you an example. Each department submits a list of tests or procedures that have no value. Good. One department decides a BUN and a creatinine and kidney function test in a inpatient on dialysis has no value. Why do it? They're on dialysis. So we look at, so they decided, let's look at 2 years of experience, 720 dialysis patients, total of 6,320 inpatient days. Almost 4,000 of these labs were drawn, which accounts for $190,000 in billable charges. Every nephrologist says, you don't need to do that. And then we say, okay, where were they drawn the most? Well, 69% of the medicine service, surgery 16%, family medicine 17%, 7%. That's Choosing Wisely. But this work was done by a third-year resident. All right, so what have I learned? You can read through this. Just some thoughts about policy change. I think every state can do it. Every state's going to need some legislative relief, probably some legislative input. This is a bipartisan issue because every legislator down the street has a family doctor and knows how important that person is to their health care. And remember, it's not about us. It's about the people of Michigan. Now I want to end with a quote from the AP yesterday. This was an interview by Senator Randy Brock, who is our governor's opponent in the upcoming election. By essentially giving almost unfettered and certainly in the United States unprecedented control to a 5-member board that has neither been elected nor is directly accountable to the people, we have ceded the control of 1/6 of our economy. Senator Brock, I agree. Here's what you need to have happen so that I can go back to being a family doctor and a palliative care physician. Okay? Let the ACO be the regulatory and policy institution. Let you, the providers, and hospital provider networks do this. But make sure they provide high quality and they work within a unified global budget. Community and critical access hospitals learn to manage to their mission rather than to a margin. Very difficult, that's cultural. The cost shift is eliminated. Clinicians drive the delivery system redesign that ensures this improved outcomes, patient experience. Everyone has access to a family physician, and 50% of medical school graduates choose family medicine careers and are not penalized by insurmountable debt. Senator Brock, go for it. Okay? So I'm very happy to answer any questions that you have, comments. It can be done here. There's no difference between the people of Michigan and the people of Vermont, except maybe marriage equality, I don't know. And I'm not a socialist. Sorry, I went over a little bit.
So are there questions for Allan? Yes.
How does the ACO model put any risk on the insured? It seems HMO put risk on me. It looks like ACO just puts the risk on the hospital who employs me, which spreads it a little bit. But I don't see how an ACO model puts it on the insurer themselves.
Two things. The HMO model put full risk on you because it was a capitation plan. There is no ACO model that will ever survive around capitation. There will be a blend of fee-for-service, bundled payments, enhanced payments, global budgeting, with per member per month enhancement. There will be a blend. And number two, your ACO, you will not be rewarded. You will not have shared savings without meeting very specific quality indicators, okay? And so your payer will only, they will be expecting to see significant changes in quality parameters. Now, that shifts some, and when we do just to give you an example, we approve all the commercial payer rate increases in the state. So a company sends us a medical trend factor, a pharmacy trend, administrative trend, contribution to surplus, to determine what their rates, how much you're going to pay in Vermont for your premium, or how much your employer is going to pay, okay? We look at that with a different lens, even right now, and they're getting the message. Because our lens is not solvency for the company. Our lens is not affordability for the insured. It is also through the lens of quality and reduction in waste. And so the accountable care organization could use those same lens in terms of negotiation with the commercial payer. Now, that whole relationship, because you're asking me, what is the sweet spot between risk? All provider, all payer. The current system is basically all the risk is on the payer. And so what does the payer do, particularly Medicare and Medicaid? Just say they won't negotiate rates. You know, they just cut rates, reimbursement rates. So all the risk now in a fee-for-service system is on the payer. In the old system that Bill and I lived through, all the risk was on me. And all I could do is just try to cut utilization. I never felt the patient experience had to improve. So where's that sweet spot? Nobody knows. There's a great, I can refer you to a great article in Health Affairs this month by Austin Drake, who describes the whole history and and asks the question, where is the sweet spot? It is there somewhere, but we will only achieve it through having efficient, high-quality delivery systems, which comes from clinical leaders, really. I don't know if that answered it. You know, I agree 100%. I feel vulnerable around that too. But I think as long as we understand we're not going back to capitation where the provider accepts full risk, and we're going to focus on quality, we'll come out of this with a sweet spot. Yeah.
So actually, we have maybe one or two questions, and then we have a break. So
Does your board have any control over capital expenditures that add to redundancy of?
Yeah. You know, we approve all the certificate of need, and anybody who comes in want to have capital expenditure of over, I don't know what the amount is now, $1 million, $1.5 million, has to go through a certificate of need process. Our state has had that for, many states have that. Totally outdated. I'd love to get rid of it. You know, we need to have a hospital give us a strategic plan, which includes their capital expenditures, includes what their technology and information system needs are, and project it out for 3 years, 5 years, and we approve it. But we're stuck with the old system right now. So we do approve certificate of need. But that's my opinion. Any press here, it's just an opinion. I think that certificate of need thing is outdated, you know, here and everywhere else. We do have it here.
So, Amy?
I just wonder, I think part of, as primary care doctors, we're sitting here knowing that there's this huge disparity between our salaries and subspecialty salaries, and that part of payment reform comes in equalizing that. So how do you sell this to the subspecialty world?
All right. You hit the top spot. Salaries will go down. If you become efficient and can control costs, you know, hey. I'm not going to say to a group of thoracic surgeons, reassure them, or a group of radiologists, that their salaries are not going to adjust themselves in this system. I just call it adjust. I am going to say that when you focus on value, the specialty that has been undervalued in perpetuity, beginning with the RBRVS system, which I hate, beginning with the changes in technology and the growth in really amazing medical advances around specialty care, the most undervalued specialty is the one that I have practiced in for 32 years. I can't imagine that family medicine and primary care salaries are going to suffer in this new system unless they don't focus on improving the delivery system and value and quality. Now, there's no guarantees around salary, but because, you know, any economist, any futurist hears this talk and says, gosh, you keep talking about efficiencies and cutting the cost trend, doesn't that mean the salaries are going to go down? I say. Do you know what a futurist is? A futurist is an economist who flunked calculus. We had one talk to us not too long ago. It was, oh my God. So, yeah, I get that all the time. Salaries will go down. We have always been a highly paid profession. Always. And our Michigan, people in Michigan and people in Vermont have always accepted that based on what they have known about the requirements we go through to achieve the professional abilities we have, okay, and the pressures on our day-to-day life. They've accepted that. If you look at value, if you look at how these pilots, patient-centered medical home, and accountable care organizations have to work with have to integrate and coordinate services, primary care physician salaries need to stay level or go up. Period. Period. And no press, right? Okay, no. Period. They have to go up. If we do the right thing for the people of Michigan. It's as simple as that. We cut the conversion factor for radiology, Medicaid radiology in Vermont. It wasn't me. We got blamed for. We get blamed for everything, but we had the Medicaid office cut the conversion factor in RBRVS for radiology procedures. Every radiologist in the state. I mean, we got public comment from all the radiologists. How many public comments do you think we got from consumers? How many public comments do you think we got from non-radiology doctors? I hate to bring that up, but that's the reality. Pricing, value failures exist in the system that we have to accommodate for. Now, maybe all of our salaries will go down a little bit, but if your salary goes down and you end the day having seen 10 or 12 patients, having worked within a really well-coordinated team, having not been hassled by prior authorizations, claims denials, claims adjustments, forms, would you accept a little bit, and you don't have a huge debt in medical school, would you maybe accept leveling of your salary? I don't know. Most of the doctors I talk to, though, it's hard to get a really honest answer out of them for that. Kind of think about it hard and say, yeah, boy, the quality of my life would really be better. I don't know. Salaries will go down. We can't recruit due to uncertainties of reform. How about the cost of new technology and research? We can't stop that. Anyway, read the list, and give me your own.
So one more question, then we have a break. So Ken.
Looking at bending the cost curve and trying to put that into where the sweet spot is. The sweet spot is currently the model that is between the payer and the provider. But also the sweet spot should include, or I would think a model to entertain is including the patient has some risk. Some states have a Medicaid model where patients have some risk, which would include the additional services based on their compliance with the risk. But looking at where's the risk for the patient, and when we're trying to meet quality measures, meet certain standards and within a framework of cost, it's that group, let's say it's 5 to 10% of our patient panel, which these costs are, and we're putting additional resources for that group who currently, in some models, are not at risk. But the question is, are there ACOs out there that are starting to look at, well, how do we integrate risk for patients because they are part of the sweet spot?
Sure. When we talk about benefits at the board level, we have a mantra. First, we talk about health. What is health? My wife is an acupuncture therapist. She practices traditional Chinese medicine. The Taoist definition of health is very simple. A quiet mind in an active body. But we do talk about it, general definitions of health. And we also say to everyone, benefits are not what we give you, they're also what you do. Okay? Now what I mentioned this earlier, what a lot of the more progressive reform efforts are looking at workplace issues around changing behavior. I mean, incenting people in the workplace. Well, you have a big stick, you got a salary, you got a promotion, to really change your behavior and looking about how we can integrate that. Because all we're doing right now in changing behaviors is selling high deductible health plans and increasing, co-insurance and co-pays. We're basically just shifting costs onto the consumer to try to change their behavior. That's never going to work, because then they just get sicker before they come in. So, it's not what we give you, it's also what you do. What does Medicaid try to do? They increase the copay for a ER visit from $10 to $50, but a Medicaid patient living on a fixed income, with no income, is not going to pay $50. It's not going to have to pay that. So we don't have any good ways of looking at that yet, other than starting with the principle that, number one, we as doctors can't be held fully accountable for all of our patients' bad behavior. That's what everybody tells me. So we have to, when we begin this process in an accountable care system of operational accountability, we have to risk stratify, understand that. But we have to have systems that assure that we've done everything we can to help that person with a behavior that has adverse health effects. And we don't have those systems yet. In Vermont, our childhood immunization rates are pathetic. They're awful. You know why? Because we have what's called a philosophical exemption rule. And we got a lot of progressive people in Vermont, okay? So that debate consumed the State House last year, where everyone was trying, the American Academy of Pediatrics, and everybody's trying, what can we do about that? That is so fundamental. But it was a politically charged issue, just like behavioral change is, and we weren't that our legislature was not able to put any real restrictions or any rules around the philosophical exemption. And the Green Mountain Care Board got a little heat for that, like we had anything to do with it. But that's an example of patient behavior, okay, that needs to change, that we need to get some sort of handle around that we just don't know of yet. Now, in a workplace, it might be a better place to deal with that is in an employee. And IBM has done, we had the National Medical Director of IBM come and tell us about their workplace wellness programs. And boy, it was impressive. It was so impressive. So.
Well, let's thank Allan again so there will be a time for a break to chat with Allan. I know a number of you invited some special guests who support our network, and so particularly the program directors, please introduce those guests to other people during the break. I want you to hold on because, as Allan said, he'd like his board to sort of disappear and then the evolution of the ACO. So in the panel, we're going to hear that in the state of Michigan. So we have leaders in the state of Michigan who are all primary care leaders who are taking charge. So we're going to hear from the UP and across the state. Allan's going to respond to these models. So it'll be great dialogue and interaction, and there'll be time for you to ask more questions. So hold your horses, come on back.